I'm trying to stream and do my live from multiple places. And so you're going to see me looking Instagram, you're here, YouTube and Facebook, you're here. You may not be able to see all my face. I'm trying something new. Okay, guys? So bear with me. If you're over on my YouTube channel, we did a test stream that didn't quite curl, but we're here, okay? So what I'm going to do, let me just tell y'all what I'm going to do and why I want to be able to do this. And so actually Instagram, I am going to actually look here, okay? If y'all don't mind. I'm going to try to do both, but again, your girl, this is new, okay? Bear with me, all right? So anyways, as you can tell by the title, I'm coming on and I am going to give some commentary over the new standards of care, the ADA standards of care. My hope is to give commentary over a standard a day throughout the month of January. That is my hope. That is my desire. It may not happen. It may not happen because I still work full time. I have children. We just got back from celebrating my daughter's birthday, and then my birthday is coming up. So there may be a couple of days where I may do like 2 or 3 standards in one day and I may skip a day. But what I wanted to do was come on and just kind of talk about the new updates with the American Diabetes Association standards of care. Now, as you know, let me give you my little spiel. I am Kim E., the Diabetes MP. I love diabetes, particularly diabetes type 2, and when it comes to marginalized groups. I talk a lot about diabetes. I've made great content on Instagram, YouTube. I have a blog. I've put out courses and all those things, but my goal is to be of service to my fellow colleagues as well as patients as well. And so one of the things that I always tell my colleagues, any clinician that I talk to, is always start with the standards. Always start with the standards. This is our guiding principles. In addition to the algorithms are a part of the standards, okay? But anything that you would want to know about diabetes management and the care of those who have diabetes, you're going to find in the standards of care. Now, the ADA puts these out every year. They tend to come out in December for the following year. So 2022 came out in December 2021. Right? And so today we're going to talk about standard 1. This is just one standard. Okay. Each one goes over a different category. So you'll have one that's just for diabetes and pregnancy. That's a whole standard all of its own. Then you have pediatrics. That's a standard all of its own. Inpatient, that is a standard, and it's very in-depth. So, of course, me being a diabetes care and education specialist, a nurse practitioner, that, this is my interest, this is my passion, this is what I am a subject matter expert in. Of course, I read the whole standard, and I do suggest that you all do that as well, but practically, I know that may not happen, okay? At least do this for me. Pull the standard that's relevant to your demographic, okay? And know that. Just know that, okay? And so anything that I can make a video off of, I start with the standards of care. So what I'm going to do is I'm just going to give commentary. I'm not going to read this whole thing to you. I'm not going to even really summarize it to you. I'm really just going to pull out what I found was interesting, what I find that is new, the updates from last year. Here's the thing about standards, guidelines, and algorithms. From year to year, if you notice, and this is not just in diabetes, this is in any guideline, there's not huge changes from year to year to year. So when you do find updates, you do need to take heed, okay? Now, so anyways, today I have my little notes, and then I have the actual standard here. I have it all highlighted and marked up. So I'm going to bring up my notes of some of the things that I felt. And again, I'm going back and forth here. I'm on YouTube, Facebook here. I'm on Instagram here. So trying to do a lot at once, but we're going to get through this, okay? And so, anywho, first things first, standard number 1 is improved care and promoting health in populations. Now, this standard is one of those standards that no matter what your demographic is, you do need to probably read this one. Okay, this is the one that you need to read, okay? This is the one that is applicable to everyone who deals with patients with diabetes, because this is it's the first one. It's like the introductory one. And so one thing that I found, one thing to note about this standard versus last year, there wasn't a lot of changes. What they felt last year is what they feel this year, okay? And so a couple of things that I want to point out is it starts out, of course, it's called the improving care and promoting health in populations. So it defines truly what population health is. Okay, and it's defined here as the health outcomes of a group of individuals, including the distribution of health outcomes within the group. Now, here's the thing about population health that is very important to all of us. Okay, it drives what we do in our individual practices, right? What's happening with the collective is what could happen with the individual. Okay, and so it starts out, that is line number 1. What is population health? And that is, diabetes, population health came here. They're like 2 in 1, So anyways, drives individual care. So you do need to know what's going on in our state, in your city, in your state, in the nation, how these things are affecting us financially, how they're affecting people as a whole person. You do need to be reading up on that. And so the stats are going to be talking about that as a whole because it trickles down. Okay. So next thing that, is a big thing to note is, as you will see, probably in every guideline, not just in guidelines for diabetes, but any chronic care management, any disease, chronic disease, is that you're going to find that there is still emphasis on patient-centered care. That's literally like the second paragraph, patient-centered care. And this is something that's near and dear to my heart, because, one thing about algorithms, guidelines, and standards, they always make room for clinical judgment, but then also they make room for the individual. And sometimes, as I am reading articles and have read articles over the years, I've been a nurse and been in classes and courses and stuff like that. Sometimes we can get into this thing where we're making blanket statements about groups of people, where here in the standards, here in the guidelines, we should really be patient-centered and patient-focused, meaning that you're taking into consideration that unique person's situation. And that's everything. Okay. We're going to talk a little bit about that a little bit here later. But when it comes to the things that I speak about, I always start there. I've had many questions from people that will say, like, especially like in medications, should I go here? Should I go there? And it's like, well, it depends on the person, can they afford that treatment? If they can't afford that treatment, then we need to go another route. But if they can, here are their options here. If they can't, here are their options here. And then what are their comorbidities? Okay. Also, you have to also keep in mind, is this something that the patient notes as important? We overlook that a lot. You know what I'm saying? Yeah, the guidelines may call for us to start insulin, but maybe that person has a fear of needles. What do you do then? So it depends. It's not just a one size fits all. And that's what the standards here talks about. That's what the algorithm's going to talk about. It's patient-centered, it's patient-focused, it's whole person care. You're looking at the person as a whole. So that's that. Another thing that is to note, I know this, but I do want to bring this up just in case there's anyone who doesn't know this. But diabetes is very expensive, not just for the individual. It's very expensive for our country. it's very expensive for your employees. For your employers. So there is a site, a government site, and it escapes me now, that breaks down, like, even if you are an employer, right, and you have employees that have diabetes, there are a lot of direct and indirect costs for a person having diabetes. It's not just their copay. It's not just their medicines. It's not just, their supplies, but they even factor in and put a dollar amount on the loss of productivity, time away from work, disability, and all of that has a dollar amount, which is something to highlight, because this is a issue. If we can prevent this on the front end, if we can prevent complications, then this kind of null and voids all the other things that comes with it. Hence why prevention is so big. Prevention of diabetes, but then also, if a person has diabetes, also prevention of complications that may come as well, because we already know that it comes with a lot of costs, not only to the patient, but to our health system, to our nation, nobody wins. Okay. And it's financial burden. It's yes, that's what it is. And I think it was, is it the Human and Health Services.gov? It's a great report. And I was just like, my goodness, and so it's very in depth. So anywho, so it does highlight that this is a very costly, disease, and it's a problem, so we got to act. We got to do something. Okay. Like last year, it brings up the chronic care model, and not sure if those who are watching, if everybody knows what the chronic care model is, but it's a great idea, but we're not there. Our healthcare system is not there, but that's what we're working towards. And there's 6 elements. I'll read them all for you. A delivery system design. So that's more so taking our approach from being reactive to more proactive, instead of dealing with it when there is a problem, showing up and being proactive. Prevention, like trying to anticipate what is to come. You know what I'm saying? We have enough research, so we need to move there, Then also self-management support. That is something that, there are tons of research, tons of articles over, activating the patient, engaging the patient, because we cannot manage their diagnosis. They are the ones that have to be in the driver's seat. They spend more time away from us than they spend with us. So we have to equip them and empower them and activate them. But that's what the self-management support is, helping them to be able to manage their disease, and make good decisions, troubleshooting, problem solving skills, decision support. So not only for the patient, but also for the provider as well. That's evidence-based medicine. That's guidelines. You're making sure that our decisions that we are making are coming from evidence and not hearsay. And not what's on the internet, though I am on the internet right now talking to you guys, but I get all my stuff from the standards right here. So, but anywho, clinical information system, that's the 4th one. The 5th one is community resources and policies. So that's really activating us to get out into the community. And, connect the dots. For me, that's really, I work in community health. So helping patients to see what's in the communities to help them, to help even offset some of their costs, sometimes totally, what's at the fingertips of them, even with their insurance companies, what their insurance companies offer that they may not be aware of. And then also the 6th one is health systems and having that quality oriented culture, that it's not a factory, move them in, move them out, but we're actually delivering good quality care. And I know that that's very nuanced. I know that we are very, we're stretched. And so that's why I said, we're not there yet, but this is what we're trying to get to. Okay. So one statement that I do want to read off here is, and that I have some thoughts on, is about optimal diabetes management. And it says here that it requires an organized, systematic approach and the involvement of a coordinated team of dedicated healthcare professionals working in an environment where patient-centered, high-quality care is a priority. Now, the thought that I have here is that this is definitely where we need to be. But as we all know, our healthcare system is fragmented. We have a lot of systems moving that are not communicating with each other. Everybody's working in a silo, and it's at the detriment of our patients, so it's not serving, it's burning us out, because in some instances, we should be delegating some things. We should be partnering with other health disciplines. And there are some disciplines that are not utilized enough. I know in my area, it does not seem like people are getting referred to nutritionists like they need to. And, the standards are very clear in how effective medical nutrition therapy is, especially in our society where we have a very warped, our portion size is off. I mean, a lot of things are off. I mean, we really need some unlearning and then relearning, especially when it comes to food and our relationship with food, but it's not utilized as much. I've also noticed that I come across a lot of patients who don't go to certain specialists. A lot of people who've never seen a podiatrist, people who've never seen an endocrinologist, and, having to stand in the gap, for them. And sometimes I think what it is that people are so busy, you can only do what you can do. And so this is what it's describing as the optimal management of diabetes, is that it's person-centered, but then that we're optimizing our healthcare team. And it's not just the MA and the provider and the staff at the office. It's that it goes outside as well, And so that was just one of my thoughts there. Something else that was a very interesting, which was also included in the standard last year, was the care teams. And I'll read this statement here. It says the care team, which centers around the patient, should avoid therapeutic inertia. For those who don't know, that means basically you don't do nothing. Like the patient, you hit a bump and you're not progressing, with your management. It says we should avoid therapeutic inertia and prioritize timely, appropriate intensification of behavior change, which they outline as diet, physical activity as an example, and or pharmacologic therapy for patients who have not achieved the recommended metabolic targets. Now, what I will say that I notice a lot, and I know this is not everybody, and I want to say I wonder if it's comfort, if this is you, or if you know what I'm talking about, drop it in the comments, what you think it may be. But I see a lot of times there's a lag with the progression of treatments, okay, the algorithm tells you that this is the next medicine that we add, but we don't do that. And this goes across the board. I'm not just seeing this with nurse practitioners. I'm not just seeing this with PAs. I'm not just seeing this with physicians. I'm seeing this across the board. Everybody does this. And I think that's why they outline this, is that we as the care team, we should avoid stalling with how we intensify our treatment, because here's the thing. The longer that this person is not at glycemic control or at their target, this puts them at risk for complications. You know what I'm saying? That will actually complicate their management even more, you see? And so I really wanted to pull that out because I see that a lot. I see that a lot. I remember being brand new as a nurse practitioner and not feeling comfortable past a certain medication. And I would quickly refer. But then the problem that I ran into is that there are, specialists, there's a wait. And so in the meantime, what do? You see what I'm saying? And so we have to be comfortable for management to a certain degree, I've even had some specialists to even tell me that they wish that people, that we wouldn't refer until it was indicated, that some things, a lot of people can be managed in primary care, So what'd you say, doctor? I think I generally think that it improves slowly when it really is. Yeah. And so, yes. And anyways, that was my thoughts there. And so next on the list, it outlines telemedicine. And I think, which I am very excited that it does make concessions for the standards do talk about COVID. Not in this particular passage right here, but it is being updated. And I think definitely we've been all thrusted into telemedicine because of COVID. But let me know about you all. I actually think that telemedicine is the way, for a lot of things, not everything, but for a lot of things, especially like education. I have found patients to be very receptive, very knowledgeable. I think at this point, there's no going back. I don't think there's any going back, because I remember prior to COVID, the only time you could really get a patient with virtual health or anything like that is if they were like in rural America. There was no, resources or providers around. And then I saw that a lot of mental health providers were using it heavily prior to, COVID. Now we're all just kind of there. One thing that it does say is that there's not a lot of studies and data on that, but I definitely see, where education can be great in this place. Consultations, that everybody wins there. I even in our area, there is a diabetes program that they do all virtually, and the patients love it. They incentivize those patients. They reach their milestones. They get their little card or their little prize. Somebody got a Fitbit. I mean, the patients love it. So I actually think I'm really excited that this is where we're going. And I actually do think that if your practice does not have some type of component like this, you need to jump on the bandwagon, because I do think this is where we're going. I think we're already here, What else do I have? Before we get into SDOH, because I got a lot to say about SDOH. One thing that it talks about is the cost considerations for medication taking behaviors. And this may not be the case for everyone's population and demographic that you see, but this is something that, pinged off something for me, because you would be surprised. And for those who don't know, I work in community health. So I go around and I go into people's homes, typically elderly. Just about everyone I talk to is rather at risk for diabetes or already has diabetes. And so I do a lot of education over just diabetes in general, and hence why I went for my certification. And so one of the things when I'm doing medication reconciliation, you'd be surprised how many people, as I'm going through medication, because I do it myself. So I'm like asking them, okay, I see that you take amlodipine, and take this for blood pressure. First off, you'll be surprised how many people don't know why they're taking what they're taking. That's for one. That's for one. Okay. And it's scary that people will take stuff blindly. Okay. And I tell them that you should ask your doctor what you're taking this for, and they should tell you, right? Somebody should tell you at that office. But anyways, but you'll be surprised how many people will be like, I don't really take that though. And I'll say, really? And my two questions are normally like, well, why is it that you're not taking it? And then secondly, does your doctor know that you're not taking it? And you'll be surprised how many people will say, I went to the pharmacy, they told me the price, and I told them they could keep it. And I'm like, okay. And I often wonder how many times in the hustle and the bustle that we're like prescribing things that people can't afford. Maybe they're in a donut hole. Maybe, right now their finances are tight. You know what I'm saying? Maybe they're tight. Are we asking people, are we actually asking people the actual question, like, are you taking your medicines as I have been prescribing them? And because people don't always tell that. They don't always tell it. And it surprises me almost on a daily. People are telling me what they're not taking. And these are like medications that they need. It's not like a Tylenol or like an aspirin. It's like heart medication, And so anywho, so that's something that really kind of, raised the little flag for me. Like, this is something that I think that it's an easy thing to overlook. It's an easy thing for us to overlook. Okay, let's get into SDOH. This is my jam, y'all. Social determinants of health is where that's my sweet spot. Maybe because since I've been a working, nurse, I have, with the exception of probably one position that I was in, I have always worked with disadvantaged and marginalized groups. Some form, whether coal miners when I was in Tennessee in rural America, or people everybody, typically everybody's always low socioeconomic. So I'm always thinking about what people can afford. Always. I'm always thinking about what's going on in their life. And here's the thing about social determinants of health. For those who don't know what this is very important, okay? And it even is outlined right here, okay? Let me read something to you. It says, health inequities related to diabetes and its complications are well documented and are heavily influenced by SDOH and have been associated with greater risk for diabetes, higher population prevalence, and poorer diabetes outcomes. So in a nutshell, how they define it is the economic, environmental, political, and social conditions in which people live and are responsible for a major part of health inequality worldwide. It's not just in our country, in the world, right? So basically, these are the non-clinical things that affect the health outcomes of our patients. Where they live, where they grow, where they work, where they socialize. Like all those things affect, whether we think it or not, it affects them. And so they do highlight some of the higher, some of the bigger categories. And we'll talk a little bit about that. But this right here is where I think that we as providers can get better at screening for this and capturing that data. Because if we know this data, then we know how to tailor our care better, right? So, I was doing a training with some community health centers. And one of the health centers, their population was homeless or houselessness people, population. Because there is a difference. Some people are displaced. So they're not what you would think, like when you think of homeless on the street. No, some people are just not in their own home. Some people are living with someone else. You think of people who live in an apartment building and maybe there's a fire. And now where are they going to go? People who evacuate for hurricanes, and have to be gone. I know, of course, Hurricane Katrina was a big one because people were gone from their homes for months. Some people never came back, what I'm saying? They just stayed where they were because they were gone that long, And so, when you start to think about that, common sense will tell you there's a lot of things that will affect their care and how well they adhere to what we prescribe and what we refer to them as, refer them to. And so it's very important. And so one thing I do want to ask you all, does your facility screen for SDOH? I know that mine does, my employer does. And it on the back end of that that charting, if things are flagged, what ends up happening is case management ends up coming in and starts to sort out some things for people as well. Planning, focus on. Yes. It's one of those things that we know is there, but it goes unscreened a lot. And, it's a lot of times it's the thing that will, by answering like maybe one of those things, or by resolving one thing, could really get a person on the right track, And so what are some of the things that they highlight? Well, they highlight food insecurity. This is one of those categories that I deal with heavily because I work in food deserts. For those who don't know what food deserts are, these are places that you don't have food markets. You don't have a Walmart. You don't have a Aldi or these places definitely would not have a Sprouts, because a lot of times they're urban. So you don't have a grocery store that's near. And what tends to be in the areas that I work in are a lot of corner stores. So what's at a corner store? A lot of packaged food. And that's what they highlight here, is that you can really see the swing of extreme hyperglycemia or extreme hypo. And here's the reason why. Let me take this. Yes, you're right. So with food insecurity, what ends up happening a lot is that, because they may be in an environment where there's a lot of corner stores or, there's not a lot of places, because you have to think about this. I see the elderly a lot. Many of them do not drive. And what to us may be just a 5-mile drive down the road is a lot for them. Some of them have stopped driving. Some of them may not afford the gas, because it's not just about buying the food. We haven't even talked about affording the food yet. We're talking about just the means to get there. That is a real thing for people. It's a real thing, And so just to drive down the road, or what we think is down the road is not down the road for someone else, right? And in some cases, it may be more than a 5-mile drive. It may be a 20-mile drive, and then when they get there, how much can they afford, And we all know that produce does not keep well. We know that. You got to eat it when you get it. And so, we know that we have to consume so many servings a day. That's very costly for someone who is on a fixed income. And so you tend to buy the things that you can afford. Well, then what does that do to your blood sugar? Pops it up, right? And then you can go the opposite way, where you got people who don't have enough. So they're not eating. And this is really big in the elderly. And then you can see hypoglycemia with them, especially if they're on medications like your sulfonylureas, like your insulins. That puts them even more at risk. So one of the things that they say here that is something that I think these are very simple questions that we can ask. And this could be a part of a screening. If y'all have a screening, check to see if you have a screening like this, that you screen for SDOH, and see if it's checking for this. But these 2 questions says simply you can ask, within the past 12 months, we worried whether our food would run out before we got money to buy more. And then the second question, within the past 12 months, the food we bought just didn't last and we didn't have money to get more. And if there is an affirmative statement here, to either one, there should be resources arranged for patients. So this is something I'm really interested to see if, if your facilities screen for this, and if so, how? And if not, do you think that this would be useful? I mean, of course, I feel like it would be useful, but do you see where I'm coming from? You see where I'm coming from here? Yes, you're right. So, so we talked about food insecurity. We talked a little bit about homelessness and housing insecurity as well. Yes, you're right. And you see how simple, just a couple of questions, one of the like I said, I do trainings for a lot of health centers of just like really helping them to optimize their care team, and then just helping with like diabetes education, and how to engage. That is really the biggest thing for providers, like how to engage patients, how do we get them to engage with us, and all of that, you know what I'm saying? Because here's the thing, the guidelines are the guidelines. They don't really change, you know what I'm saying? But it's how we deliver our care is if they're going to even listen to us to even get to the guidelines. You see what I'm saying? Like, so you have to talk people's language. Like if you're asking questions like this, what that fires off to people is like, she's really trying to like see what's going on with me for real. Like, I love the statement that what's the quote? People don't care how much you know until they know how much you care. To John Q. Public, they don't care about all of our certifications and what school we went to. They don't care about all that. They don't know what that means, honestly. They want to make sure, especially there are certain generations, especially like the older generation, they're big on respect. They're big on, do you treat me with respect? Do you treat me like a human being? Do you listen to me? Do you look me in the eyes? Do you, like, those are the things that I think that we can overlook. I think that's very good, Winks Live. We screen, then set them up for a commodity or refer them to social work. Yes, that is good, because that's not the norm for everyone. Okay. So anyways, something else that I want to keep in mind, and I've had just a tad bit of experience with this population, and this is migrant and seasonal agriculture workers. Do you realize, just think about it, how challenging it would be to provide care for this group of people, and the nuance with it, and how it has to have, you have to deal with it in a different way. So if you don't know what a migrant agriculture worker is, basically they're the backbone of our country, of a $1 billion business. These are people who go out and farm our crops. It is, statistically, it tends to be people who are of Latin descent. But here's the thing, they move with where the work is. So you may not get, and I did have a community center that's who they serviced. And that was a big issue of theirs, is follow-up, because they're here today and they may not be here 6 months from today. And, of course, language barrier can be in some cases, but the way that you deliver your care is not a one size fits all. And we all have our unique population, our demographic. And so, they highlight that here in the standards, really highlighting that like, even like the considerations, what we're anticipating, because that's really half our job is anticipation. What are we anticipating? What are the challenges that we're anticipating? One thing about migrant workers, as well as those who are homeless, storage of things like insulin, supplies, those are things that we have to consider. And then we write all this stuff and we wonder why our numbers are not adding up, and it's like, because all this stuff is going on the background, right? And so then last two things, health literacy and numeracy. This is another thing that I do believe is overlooked, because I think people can present their best to us. And I think also, I have had probably a handful of patients over my career that were highly successful people, but were illiterate. They could not write or read. They just had gotten very good at what they could do. And they had people around them that supported them very well. But they were very successful. And, I've always thought to myself, had I not have just asked a simple question, then I would have thought that they were able to read a research paper. You know what I'm saying? Because of how they presented themselves. You know what I'm saying? And, so that's literacy, but then we have health literacy and numeracy. And that's something that even a highly learned person could have low health literacy. By definition, it says that it's the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate decisions. How many of us have had patients where their children are speaking for them for whatever reason? Maybe they get nervous. Of course, we have dementia and things like that, but then you have some people that maybe their spouse is the one that makes all the decisions for them. I get that a lot. Like the wife makes a lot of the decisions for her and her husband. He doesn't know. You ask him a question, he doesn't know what's going on with him, but his wife knows everything. You have to consider that. And what's the support behind that? Numeracy, our patients, especially in diabetes, definitely need to have a level of numeracy. And that is something as simple as, now what it says here, it's important in diabetes prevention and management because it requires primary numeric skills, things like being able to perform like tasks like interpreting food labels, and then medication adjustments, understanding what that is. Like that's what your health numeracy is. And we have to consider that. And what if you get a patient that is in that category? Just like if you have a child who's learning how to read, you work with them. You just work with them. You meet them where they're at, and then you get them up to standard. That's where you do. That's where you go. You break it down for them. You bring in support, bring in family support. If it is that husband that needs his wife there. I have definitely had many of husbands. And I've had some husbands to have to speak for their wives as well, that's like, okay, let's write this out. Let me make you a diagram. I'm good at drawing something. All right. And then lastly, it talks about social capital and community support. Now, here's the thing about this. Now, it talks a lot about bringing in the community resources and bringing in, community health workers and, lay leaders in the community. And I think that is awesome. I'm not saying that it is not, but every time I read something like this, the first thing I think about is, because the whole idea is bringing in that community support so you can be able to be in the community more, like you're represented in the community more. And, the idea is that using, community health leaders and, peer supporters and things like that, they can help with like advocacy and education and basic health education and referrals to your clinics and things like that. And, rallying up the troops. But the thing that I always think about is this. Why don't you just hire people who represent the community that you are servicing? So, for instance, if you are servicing people who are, let's say, Mexican, you should try to find providers and staff that are Mexican. If you service the LGBTQ plus community, it may do you good to find a provider that can relate to the community, whether because they're a part of it, maybe because they have experience with it, what have you. There's people out there, think about as women, we go to the OBGYN, there's all women in there. How many of us feel comfortable going? I personally have only had a female OBGYN, have only had one. When I am talking about the things that I am going through, I don't have to convince her that what I am going through is what I'm going through, because she already knows. She already knows. Of course, I'm Black, so if you are someone that your clinic services Black people, you should have Black people that they see when they come in there. Not to say that you cannot see people who are not like you, but your clinic should really be like a rainbow coalition, I think. We should represent the community that we see. And if we're supposed to give care to all, then that should be represented in our clinics. And that may not be, but it may be why your patient engagement is off. not in the area that I'm in so much, but again, talking to colleagues, I had a colleague that heavily, they did Native American health, and they worked on the reservation, and they had staff that were Native American because they understood and then could educate other staff members over the traditions, over the things that were going, over the different things. So now you're not coming from a place of, I just have a good heart and I just want to serve everybody. No, I actually know how to approach the people that I'm serving, where I'm not offending, where I'm actually incorporating their culture because I've been educated, and it's unheard. Like we're not going to, in the world that we live in, we're outnumbered as providers. So, it would be unheard of to say that, okay, I'm going to go find a person. We see LGBTQ plus, so we're going to go get all our staff is going to be LGBTQ plus. That's not what I'm saying. I'm just saying, make an effort, because let me tell you something. I was perusing around on LinkedIn, okay? And as you're perusing around on LinkedIn, you see job openings. And I saw a job opening that specifically requested a person who not only spoke Mandarin Chinese, but that was Chinese. It said, we are looking for a Chinese nurse practitioner that speaks Mandarin Chinese. People are willing to relocate. So even if you can't find one in your community, you can put a job posting out there for it. At least try. Or then at least try to incorporate, really understand the demographic that you service. You don't have to know all cultures. You just need to know your demographic and try to better serve them. We are of service to them. They're not here for us. We're here for them. Now, I'm not saying that we should be beat up and abused and all that stuff, used and abused. I'm not saying that. But I would have to say, assuming positive intent for all of us, that we all went into this wanting to help and serve people. And so we have to remember that. They're not here. And I'm going to tell y'all right now. I'm going to tell you right now. My patients that I see, I have heard horror stories of some of the experiences that they have had. Some of them I'm like, but then some of them I'm like, wherever. And I always tell them this: you're not doing any of us a favor. This is a business relationship. We're giving a service and we're getting paid for that service. So then that means a certain level of customer service is required. I know that some of us don't want to think about it like that because we're so learned and we have all these degrees and we have all these, certifications. But at the end of the day, when you peel all that back, we're service providers. And you can throw a rock and hit another clinic. People don't have to come to you. They don't have to. And I tell people that if you're not satisfied with the care that you're getting, go somewhere else. Because not only do you have these big health systems out here that have all the resources to pour into whatever they need, you also got a lot of people that are popping up with their mom and pop clinics. A lot of us are opening up our own clinics. There's a lot of competition out here. This is not something that you want to put on the back burner. And so again, how we deliver care is going to be the differentiator. That's going to be whether your reputation is going to fly or sink. But anyways, guys, this was great. Again, like I said, Instagram is here, YouTube and Facebook, you're here. I was trying to also go live on LinkedIn as well. I was trying to do a whole bunch at once. We're trying, I'm trying to go live. And so what I'm going to do, what I'm going to try to do is, I cannot promise I'll be on here every single day, but I'll be here every so many days and we'll go over the standard. Today was standard 1. The next time I come on here, we'll be talking about standard 2. And I'll just want to pop on and do this live throughout the rest of January. And so let me know if you guys like this. Definitely put your commentary in as well as you're reading. If you have read the standards, if you plan on reading the standards, Again, you guys, you've been sitting here with Kim E, the Diabetes MP, and I will catch you guys later. Bye.